Okay, we will see about a few of the common vestibular pathologies. So, if the patients are coming with a vertigo complaint, so we have avoided the dizziness and lightheadedness. Now we are concentrating on the vertigo. So, these are all the pathologies, common pathologies, which has vertigo as one of the symptom. Okay, so we will first go into the BPPV, benign paroxysmal positional vertigo. Benign means it is not life threatening. Because of this, there is no problem. This is not a disease. This is not going to increase by time. Okay, that's benign. And paroxysmal is a sudden attack. This is not gradual. This is very sudden attack. And positional vertigo means the vertigo is initiated by a change in the position, maybe a change in the horizontal position. We saw three planes of motion. One is your pitching front and back, and then your yaw, which is turning right and left, like saying no. And then you have your roll, which is tilting head right and left, as if you are touching your right and left shoulders with your head. Okay. So if a patient is reporting that I did this change in the position, that I might turn my head towards the right or left, I bend down, and I'm having a sudden vertigo attack. So then this is indicative of a pathology called BPPV. Okay. Paroxysmal means sudden. Okay, what is the characteristics of this BPPV? This has brief episodes of vertigo, which means the vertigo is not just sudden, it is very short. Okay, which means it will be less than a minute. If you change a position and you have a vertigo and it subsides in a minute or two, that's it. It is not a long nystagmus or long vertigo. It is a very short vertigo. Okay. Then what actually is this BPPV? This BPPV is not uh, a problem with firing or with the brainstem or anything. This is exactly in the peripheral end. This is a mechanical dysfunction. Okay, and as it continues, imagine a patient is having a BPPV and the patient didn't come for 6 months. He was trying to adjust with it. Will it increase? No, it will not increase. Okay, this is not a disease process which will not increase. What happens? Why do we have BPPV? Earlier we saw that the saccule and the utricle, these are otolith organs, they have otolith membrane. Okay, on the otolith membrane we had otoconia, right? Otoconia we had, those are uh, calcium carbonate crystals. What happens is maybe because of a blow or an accident or any reason, few of these calcium carbonate crystals are dislodged. They are removed from the otolith membrane. Now they are free floating. Okay, what they do, the utricle's otoconia is removed, not the saccule. Okay, because if it's removed from the saccule, we have no problem because utricle and saccule are not connected. Utricle is connected to the semicircular canal. Saccule is not connected to the semicircular canal. Right. So these otoconia, when it's removed, dislodged from the otolith membrane, since the semicircular canals are in direct connection with the utricle, the otoconia will go enter into any of this semicircular canal. Okay, if this enters into any of the semicircular canal, because the otoconia has a mass, it has a weight, it's like a stone, and this is able to create a kind of a stimulation of the vestibular semicircular canal. Okay, in a semicircular canal, if it enters, this otoconia has the capacity to change or the orientation of the cupula. Okay, if the cupula is changing, what does it mean? It means the head is moving. Okay, and this keeps rotating inside, it keeps deflecting inside, producing an effect that the head is still moving. Okay, the patient changed once from straight to the right. But because of this free floating otoconia, what they do is they keep rotating in the canal. It gives an effect that the patient is rotating still. Okay, so one ear is giving this kind of a excitatory response, and the other ear is giving inhibitory response, and stopped, the brain gets confused. Okay, when the brain get confused because of two mismatch input, one from the right, one from the left, and they are mismatched, then the brain get confused and it starts nystagmus. Okay, nystagmus, and it has vertigo. Okay, the BPPV is not one kind. There are many types based on to which semicircular canal this otoconia goes into. Okay, mostly the BPPV reported this majority of the patients are posterior canal BPPV. Okay, which means the otoconia will go inside the posterior canal. But there are also cases where it has went into anterior and lateral or horizontal, and there are also cases where it has went into more than one semicircular canal. Okay, so it will go into more than one semicircular canal. So what will happen? It will show mixed symptoms. Previously we saw the nystagmus, the eye movement is connected with the semicircular canal orientation. If there is a deflection in the horizontal canal, my eyes is going to move towards right and left. If there is a problem with the anterior, okay, then my eyes, the nystagmus is going to be up and down. Okay, and if it's going to be my posterior, then it's going to be rotational. Depends on which semicircular canal is getting excited. Okay, the horizontal is very simple, right and left, but anterior and posterior, there is no simple up and down movement. Okay, it is up and down and rotational, torsional. Okay, and we have a video which defines what a torsional vertigo is in the forthcoming slides. Okay, the next vestibular pathology is the vestibular neuritis or neuronitis. Both are same. Okay, what is this? This is actually a viral infection. Okay, previously the cause for that was the dislodging of otoconia. Here, the vestibular symptom or the vertigo is caused by a viral infection, the viral infection in the nerves. Okay, so what happens? This is a sudden onset of vertigo, just like the BPPV. Okay, so how do we differentiate? The difference is it is not positional first. Okay, it happens continuously, it is not positional, and it doesn't have brief but prolonged vertigo. Previously BPPV was just short episode of vertigo, but this one is a prolonged vertigo. It can last for a day or more. Okay, plus it will have sensation of nausea and vomiting. Okay, this is how we can differentiate the pathologies, although these are just understanding of the pathology. This is not exactly diagnostic. These symptoms doesn't help us to diagnose, but to have an idea before we start a test. Okay, the next one is Meniere's disease. Everyone knows it, but in the audiological point of view. So why do we have Meniere's disease? When the production of the endolymph is increased, so your cochlea is actually, the endolymph is actually bulging. So this will called as the endolymphatic hydrops. So when it bulges, what happens? The pressure inside the endolymph increases. Okay. So how do we have the diagnosis of Meniere's? The Meniere's disease has triad symptoms. It has vertigo, it will have tinnitus, it will have oral fullness. Okay, so the tinnitus is associated with your hearing loss. Okay, so if there are four symptoms, which is the hearing loss as the fourth symptom, the hearing loss will be associated with the tinnitus. Okay, so you have vertigo, we have tinnitus, and oral fullness. If a patient is reporting of all these three, then we are going to suspect this patient is having a Meniere's disease. Okay.